Well, good evening, everybody. My name is Phil Flanagan from the Northwest Melbourne Primary Health Network. We're starting very promptly on time this evening, and I'd like to welcome you to our webinar, which is jointly presented tonight on behalf of Northwest Melbourne PHM, also with our colleagues at Mercy Health. We have various colleagues on board tonight that make this webinar work. We have Sharon Tyson from Mercy Health. We have Crystal Barbetto from Health Pathways. I've got my colleague Yvonne Beese from Northwest Melbourne PHN, who's done all the real hard technical work. And we have our guest speaker, Dr. Alexis Shub, who will do the main presentation this evening. So thank you again, everybody, for coming on board tonight for our new gestational diabetes mellitus guidelines and management webinar. On behalf of Northwestern Melbourne Primary Health Network, firstly, I would like to acknowledge the traditional custodians of the land on which our work takes place. That's the Wurundjeri Woi-wurrung people, the Bunurong people, and the Wathaurong people. I'd also very much like to pay my respects to elders past, present, and emerging, and also pay my respects to any Aboriginal and Torres Strait Islander people who may be joining this webinar session this evening. Thank you. So everybody, just in terms of what we're doing tonight, we are actually in a Zoom webinar, and I'd just like to go through a few little basic housekeeping formalities, if I may, before we get started, so we sort of know how things work this evening. Firstly, everybody apart from our speakers will be muted this evening, so if you can please bear that in mind. But notwithstanding the fact that people are muted, of course, we're very interested to receive your questions during the course of the presentation this evening. The important thing, please, to remember is if you can please put your questions in the Q&A box only. That way they won't be lost in the chat. And then at the end of our presentation, then Dr. Shah will be very happy to go through the questions that have been put forward during the course of the webinar itself. The other thing I'd like to remind everybody of, please, is that the session is being recorded this evening, and you will receive a link to the recording and a copy of the slides in the post-session correspondence and or any other information that may get referred to during the course of the evening, say with Q&A, or that may be brought up as part of the presentation. We'll make sure you receive that post the presentation this evening. And of course, questions will be asked anonymously this evening to protect your privacy. The other little bit of housekeeping I'd just like to remind people of, if I may please, and this is quite important. When you've joined the session tonight, we would like you to make sure, please, that you have joined the session using exactly the same name that you registered with, or if you did register using a phone number, can you please double check that you're using the same phone number or ID for your phone. This is really important because Northwest Melbourne PHN uses the Zoom's participant list to mark the attendance and the certificates and the CBD that will be issued to you. And unfortunately, if we can't match those details, then we will be unable to confirm your attendance. So the best thing to say is if you're not sure if your name matches, please put a little note in the chat message. Just mark it for the attention of Northwest Melbourne Education and to identify yourself, and then we can marry that up at the end of the session to ensure you do get your CBD points. And without any further ado, I might pass over to my colleague now, Sharon Tyson from Mercy Health.
Thank you, Phil. Good evening, everyone. I'm the Primary Care Liaison Officer for Mercy Health, and I'll just have a tiny bit of information. Mercy Health is very excited that we've created a new and improved mobile-friendly newsletter. So if you haven't signed up yet to the Mercy Health newsletter, please ensure you do so. It will be hyperlinked in the slides. We've got one for Mercy Hospital for Women and a separate one for Werribee Mercy Hospital. And the other thing that we would like to ensure that everyone is aware that the Mercy Health prefers way of referrals is to outpatient specialist clinics, I have to say, sorry, is receiving referrals via HealthLink. We do have a special website with all tips, tricks, fact sheets, and if there's anything else, there's also phone numbers and contact people on there. So please ensure that we all use HealthLink e-referrals. That will be very much appreciated. Thank you very much, everyone.
Thanks, Sharon. That's wonderful. Thank you for the update. Now I think I'm going to hand over to my colleague, Crystal Barbetto from Health Pathways, who'll just give you a little bit of information about what you can access via Health Pathways. Thanks, Crystal.
Thanks, Phil. Good evening, everyone. My name's Crystal Barbeiro, and I'm the Program Specialist at Health Pathways Melbourne. I know you've got a big session in front of you today, so I'm just going to quickly do a highlight session of why Health Pathways is relevant to your practice. It's just to demonstrate how the platform can serve as an invaluable resource, enabling you to quickly access the information that you require while you're with your patients. Health Pathways is a collaborative online resource which is developed by Eastern Melbourne and Northwestern Melbourne primary healthcare networks in partnership with healthcare professionals and organisations in the Melbourne region. The process of developing content is a collaborative effort between our GPs, specialists, allied health providers, and other subject matter experts. Each pathway is evidence-informed best practice, but also reflects local reality. We aim to enhance clinical knowledge and promote best practice, reduce variation in care, improve quality of pre-referral workup, and reduce delays with referral, and provide you with information on local services available to you in your local area. Today, this presentation will demonstrate how to access and navigate Health Pathways Melbourne to find relevant pathways on endocrinology and specifically diabetes in pregnancy. I'm now going to, the next slide, hopefully technology will allow it to work for us. I'm going to hit play on a navigation slide, which has been provided by one of our project officers, Jane Barbiti, who is currently working our endocrinology suite in conjunction with the clinical editor, Dr. John Omar.
We can't hear that, Crystal.
Okay, I'm just going to pause. Okay. Okay. My apologies. Okay. So what we do have here is we have our hypoglycemia in pregnancy pathway. This one here, as mentioned previously, has just been updated. Throughout the clinical pathways, you'll find assessment, management, and referral sections. You'll find drop boxes throughout the pathway, which will provide additional information. We'll have additional information. I'm so sorry, I've got it playing in my ears as well, but you guys can't hear it, so I sincerely apologise for this. This pathway here has just been updated and gone live as of the 15th of this month. As soon as the new diabetes GDM guidelines are released, we will aim to have those embedded within our pathway as soon as possible. Okay, I'm just going to unfortunately jump right forward because I apologise that it hasn't worked out the way that we hoped. However, we'll jump straight on to our next one. So here we have our relevant and related pathways under the endocrinology suite. You can see these three that have been popped here and underlined in blue are the most relevant for this evening's presentation. As previously mentioned, the wider endocrinology suite is currently under review. If you'd like to be alerted about any of these pathway updates and when the new ones go live, users can subscribe by the monthly Health Pathways Bulletin or check the Pathway Updates section on the homepage. Additionally, we do have a CPD IELTS for health pathway use. So you may not be aware, but it is a tool that can help you with your reflective learning. If you have a look here on the right-hand side of the screen, you'll see that you can create a CPD report, which you can then upload for the RACGP and the Australian College of Rural and Remote Medicine. Accessing health pathways is extremely simple. Clinicians who work within the Eastern and Northwestern catchments can register for access to Health Pathways Melbourne by visiting our website, and you can create your own individual login. And that is the end of my presentation. Apologies for the tech problems there. Phil, I shall hand back over to you.
Many thanks indeed, Crystal. And I should like to add that, of course, any resources that we have referred to this evening, they'll come to you after the presentation. You'll be able to access them live as well. So thank you again, Crystal. Without any further ado, it gives me great pleasure to introduce our keynote speaker and presenter this evening. Associate Professor Dr. Alexis Shub is a maternal fetal medicine subspecialist and obstetrician at Mercy Hospital for Women. Dr. Shub is head of the hospital's diabetes clinic, a board member of Australasian Diabetes in Pregnancy Society, ADIPS or ADIPS, depending on where you're from, and author of the latest ADIPS guidance on diagnosis of GDM. Dr. Shub has many years of experience in caring for pregnant women with diabetes, and without any further ado, may I please hand over to you, Dr. Shub.
Great, thanks very much, and thanks for inviting me to speak tonight. We'll just see if we can get my tech to work. So, go. Okay, great. So I'm going to talk about gestational diabetes, but happy to answer questions on other kinds of diabetes in pregnancy or other bits of antenatal care, if that suits anyone. So my conflict of interest is I am a member of the ADIPS board, but I'm not speaking tonight representing ADIPS. So my statements don't necessarily represent ADIPS opinions in everything, and some things are more concordant than others. What are we going to talk about? We're going to talk about what's new in GDM, and particularly this is around a guideline which is due to be published in the MJA in the next few weeks. I cannot tell you how frustrated we all are that we don't actually have a date for that. And it brings in some very big changes, particularly around early testing and diagnostic criteria. So we're going to go through that in quite a bit of detail because it's a big change. It's been a long time since we've had this kind of change, and lots of people feel a bit uncomfortable about it. So I want to try and explain why some of those changes have come in and why I think that they're improving our care. I'm going to talk a little bit about what I think should be new in gestational diabetes, which is metformin, and then a little bit about some other bits and pieces if we have time, particularly around breastfeeding and expressing, and some of the other topics people may want to talk about. Really, I haven't got slides around them, but around some of the GDM topics that aren't always talked about: body shame, stigmatism, normalisation of care, some of those other things that we won't cover in detail, but are kind of there in the background as well. So there you are in your rooms, and one of your patients comes in, and it's Amanpreet, and she's very pleased that she's come to see you at 5 weeks to confirm that she's pregnant and make plans for her pregnancy. This is baby number 2 for her. She had a baby a couple of years ago in India, normal delivery, 3.2 kilos. Breastfeeding was a bit tricky, but apart from that, as far as she's concerned, things were pretty okay. So what I want you to have is think about, given that this is a talk about gestational diabetes, there are of course lots and lots of things that we could talk about with her in that first visit, but given we're talking about gestational diabetes, what else do you want to know and what are your plans? She didn't have a diabetes test last time, not because she refused, because it didn't just happen. She's overweight, her BMI is 29. She's got a strong family history of diabetes, with her mother being diagnosed with type 2 at around 50. She's actually, it fell off my slide, she's actually on metformin for some reasons that are a little bit unclear to everyone, including her, but she's taken some metformin, maybe irregular periods, a little bit hard to know. Her mum is going to come and stay from 20 weeks. Mum's coming from India. Make sure she eats well, doesn't overexert herself in pregnancy. And you decide, based on all of that, you're going to do a GTT, which comes back with those numbers, and you also do a hemoglobin A1C, and the question is, what are we going to do now? So let's work on where we think some of her care should be. So I'm going to come back to this slide a few times because it's a big change. In blue is the current ADIPS recommendations around diagnosis of GDM, and they've been fairly widely accepted by most of the hospitals. They've never been endorsed by the College of GPs, and I don't know the history to that, but that's been a point of difference across the many years since these were published. And so I'm sure you're aware that we have been doing early GTTs for women with risk factors. And with that very long list of risk factors, we've been doing a 75-gram glucose tolerance test for everyone else at 24 to 28 weeks. And we've been using those diagnostic criteria 5.1, 10.0, 8.5 after a 75-gram oral glucose test. So the changes that are coming in, which have been endorsed by many organisations, and I just want to make sure I get the wording right on what RACGP have said. They've not endorsed the document, but it's been officially recognised as an accepted clinical resource. And College of O&G, College of Pathologists, Rural Medicine, many other organisations have accepted these guidelines that are coming. So we're going to work through these and why they've come through. So hemoglobin A1C for women with risk factors for diabetes to diagnose type 2 diabetes, early GTT for a much smaller group of women, and we'll get to the other ones in a minute. So let's go back and talk about why we care about gestational diabetes and what we actually know and what we don't know. So gestational diabetes, we know, causes obstetric problems, macrosomia, big babies, caesarean section and shoulder dystocia, probably both secondary to the fact that we get bigger babies. Not all big babies are caused by gestational diabetes. Some big babies we get for no reason, and there's a very strong link between obesity and big babies separate to gestational diabetes, but certainly these things are linked to GDM. We know that babies are more likely to have hypoglycemia. If mum has GDM, we know there's more likely to be birth trauma, again, secondary to size, more likely to be respiratory distress, and more likely to be jaundice. We know that women themselves are much more likely to develop type 2 diabetes if they've had gestational diabetes. And there's all sorts of numbers out there, 25% risk at 15 years after the pregnancy, all sorts of numbers over different timeframes, but certainly much more likely than someone who didn't have gestational diabetes to develop type 2 diabetes. And that's one of the really important things about GDM, is that we can use it as a risk marker to try and talk to women about diet and lifestyle and all those things to reduce their chances of type 2. And we know that women with gestational diabetes their children are more likely to develop obesity and cardiovascular disease. It's intergenerational impact that we see from the gestational diabetes. So all those things are important, and we should be working to prevent those things. And just a reminder that when we talk about shoulder dystocia and some of those things, sometimes it's, stressful at the time, but the baby's okay. And sometimes we end up in this kind of scenario. So this is actually the baby of one of my mums with type 2, not with GDM. This baby was 3.7 kilos, not a really big baby. And the baby got terrible shoulder dystocia. And as you can see, got HIE, intubated, NICU, all of the things that we don't want to see. And that's probably because infants of mothers with diabetes, gestational or other diabetes, are built a bit differently. They're built like rugby players. They've got the big shoulders, and that's why shoulder dystocia is more of a risk. So although many of the problems are very manageable, there's some pretty important stuff going on as well. So we know those things are associated with gestational diabetes, but we're always stuck with the difference between association and then what we can actually fix. So what problems are improved by treating gestational diabetes, what problems are caused by treating gestational diabetes, and what problems are not caused by gestational diabetes. Let's just run through those. So the big randomized trials of GDM showed that for the woman, she has less weight gain, she has less preeclampsia, and there was a trend towards a lower caesarean section rate, but not a statistically significant difference. And I've just used the little stars to demonstrate statistical significance. For the babies, a bit smaller and less shoulder dystocia. But what are the costs of all of that? What are the things that impact on women and on the system in terms of our treating GDM and in terms of what benefits we get? So obviously, if we diagnose somebody with gestational diabetes, we get them to do home blood glucose monitoring. And so there's a social cost to that. It's unpleasant to be finger pricking 4 times a day. And there are financial costs to the system around the strips and the meters and those kinds of things. Between 30 and 50%, depending on where you set your gestational diabetes targets, will end up on insulin. That's, again, cost to the system, very unpleasant for the woman. Often more visits to the hospital, sometimes change in model of care, increased induction rates, increased admissions for babies to special care, And again, all those things have both financial and social costs. And then there's the stigmatization and sometimes the guilt that can go with a diagnosis of gestational diabetes. So we need to think about all of those things. What doesn't treating gestational diabetes fix? Very sadly, and I'll show you some detail because it's very disappointing, it doesn't fix the intergenerational outcomes. So for the work that we put into treating GDM, we don't change those long-term outcomes for those children. And treating gestational diabetes doesn't fix miscarriage or congenital anomalies because those things are early pregnancy blood sugars, and they're not women with gestational diabetes, they're pre-pregnancy diabetes. So we just need to make sure that women aren't feeling bad about those things when they're not actually related. So a lot of detail, but because it's very depressing, about why treating gestational diabetes doesn't make a difference to the long-term outcomes. And when we talk about the fact that we're going to diagnose less women with gestational diabetes, which we are going to talk about in a minute, this is one of the things that bothers people. What do we lose by treating less women? And are we harming children going forwards? So if we look at the RCTs of treatment or not treatment of GDM, people have looked at all sorts of outcomes. So I've listed them there if you do want to read them. So fat mass at 6 months in the babies, no difference between treatment and untreatment. BMI in the children at 5 years of age, no difference whether we treat or don't treat. 5 to 10 year outcomes of BMI, waist circumference, lipids, blood pressure, insulin resistance, no difference whether we treat or don't treat. They did manage to find that the female babies only had lower fasting glucose at 5 to 10 years. You do wonder if that's a multiplicity of outcomes problem rather than any difference. If we look at a meta-analysis of treating GDM rather than these individual trials, no difference in childhood obesity. And then there's some observational data, again, looking at women with GDM, looking at and obesity versus just GDM, observational data, not randomized control data, and the lowest risk for adolescents overweight was in the women with GDM compared to those other groups. And then if we look at childhood obesity in an observational study, again, we can see that it's more related to lifestyle factors. So I think it's really, really disappointing that for the work we put in, we don't provide benefit for those children and adolescents and presumably lifelong changes. But if we're treating less women for gestational diabetes, which is what we're going to do, we're not causing harm to those children. Okay, so we just need a few definitions and a little bit of background around gestational diabetes. So that this slide that we've got here on the left is from the Harpo paper, which was published a long time ago now, but was an observational study of around 25,000 women across a range of countries and looking at blood sugar, looking at GTT results at 24 to 28 weeks, and then obstetric outcomes. This is observational only. The GTT results were blinded. Women weren't treated for gestational diabetes. This is untreated. And what you can see, and the colours show you fasting 1 hour and 2 hour glucose, you can see that there's a continuum, that there's no cut point at which we say, this is gestational diabetes and this is normal. You just have to decide where along those continuums for birth weight, cesarean section, neonatal hypoglycemia, and C-peptide, which is a surrogate for insulin, where along there you want to decide is abnormal. And what we did when the last guideline came out about 10 or 12 years ago, we decided that we'd use a 1.75 odds ratio, so Harpo 1.75, to define where we call gestational diabetes. So you were 1.75 times more likely than the mean to get the outcomes of birth weight, cesarean section, those things. And that's where the 5.1, 10.0, 8.5 came from. What was discussed at the time was using different cutoffs. So using an odds ratio of 2.0, or in fact using an odds ratio of 1.5. And the numbers that are used from the 2.0 odds ratio is 5.3, 10.5, 9.0. And as I showed you on that slide before, that's where we're going. So it's just picking where on that continuum you want to define gestational diabetes and how much benefit you get from treatment and how many women you define as having disease. So that's where those numbers come from. We're going to talk about why they were chosen. The other thing that we're going to talk about today is early and late gestational diabetes, and I'm using early GDM to mean any GDM diagnosed before 20 weeks and late GDM, or just GDM, as our standard, which is diagnosed at the 24 to 20. Okay, so when we think about early testing for GDM, we come back to the paradigm that comes into lots of screening tests, of which GDM is a screening, OGT is a screening test, if we treat it earlier, do we make more difference? So you can think of that analogous to breast cancer screening, all kinds of things, prostate cancer screening. Is it better to pick it up earlier? And what we have to think about with that is, first of all, what the trials have shown us, but also what we know about blood sugar changes in pregnancy, which we're going to talk about, and what about the changing demographics of our population. So we know, I want to talk about the demographics first. We know that type 2 diabetes has very clearly demonstrated risks in pregnancy, and we know that it's much, much more common as we've continued on over the time, even the time that I've been doing this. So in the time that I've been looking after the diabetes clinic, when I started 18 years ago, we had about a sort of 80% type 1 diabetes, 20% type 2 diabetes in pregnant women. And we now have more than half type 2. So certainly type 2 is much more common than it used to be, to do with changing country of birth, to do with age, to do with BMI, much more common. And as you all know well, hemoglobin A1C is a good test for screening for type 2 diabetes. And that's why we're incorporating it into our early screening, because one of the things that we do want to do is pick up the women with type 2 diabetes early in pregnancy. We think about blood sugar in pregnancy. Now, this is some Chinese data, and therefore may not necessarily extrapolate across other ethnic groups, but it's such nice data that I wanted to show it to you. So what it shows is the mean fasting blood glucose at various gestational ages. So on the left, we've got 4 to 6 weeks, coming across to 20 to 22 weeks at the end. And what you can see is fasting glucose falls in normal pregnancy. This is a very large cohort of observational data. So the mean blood glucose, 4.95 in early pregnancy. And if we overlay that with where we've used the cutoff for fasting blood glucose to define GDM using our 5.1, which is where we've been for the last however many years, you can see that in this Chinese cohort, around, when the numbers are on the right here, around nearly 40% of women have a blood glucose over 5.1 fasting at 4 to 6 weeks pregnant. And if we'd done the test 2 weeks later, that would be different, and 2 weeks later, that would be different. So fasting blood glucose in very early pregnancy is quite a problematic test because of the normal ranges. And again, just another way of looking at some of this data, just to show why early pregnancy is a little bit problematic. This is some data from the US with women who wore CGMs in pregnancies before they had a test for gestational diabetes. And then they all have a test at 24 to 28 weeks. And the women in red are the women who are later diagnosed with GDM. And the women in blue are the women who are never diagnosed with GDM. They have a negative GTT at 24 to 28 weeks. And these are box plots, so the dots and the lines are the means and the median. And what this is showing us on the left is the percentage of time on CGM monitoring, continuous glucose monitoring, that they spent over 6.7, which would be our cutoff for starting insulin. And what you can see is there's a difference between the women who are diagnosed later with gestational diabetes and the women who are not diagnosed with gestational diabetes. But even in these blue ones, so here we are at 13 weeks of pregnancy, these women are spending 15% of their time over 6.7, which would be our treatment threshold. And again, that falls as we go through pregnancy. So blood sugars are higher in early pregnancy than they are later in pregnancy. And that's why early testing for gestational diabetes, just on the physiology, is quite problematic. But let's look at the RCT data about what happens. So Toboggan is a Australian and international randomised controlled trial, an enormous effort to go into this trial. They screened women who are high risk for GDM based on all of those things that we're used to, ethnicity, BMI, previous GDM, and they did a GTT on them, and they got 800 women with a positive GTT before 20 weeks gestation. So all high risk, all positive. They were randomised, and half were treated for gestational diabetes, and half the positive result was concealed, and they were retested with another GTT at 24 to 28 weeks. So it's a huge amount of work. You screen a whole lot of women, you do all sorts of things. Anyway, always impressive when people do trials like this. They had 3 primary outcomes to this trial. Hypertension and preeclampsia, based on that data we saw that said that there's a reduction in preeclampsia with treatment of GDM, no difference. Neonatal lean body mass, to try and see if they could influence macrosomia, no difference. and then a composite neonatal outcome, which was reduced in the early intervention group. So 3 primary outcomes, always good to hedge your bets, and one of them they saw a difference. The trouble is, and this is where I have some issues with this trial, is that there were a number of components of the primary neonatal outcome, preterm birth, birth weight, birth trauma, all sorts of things. The only one that they saw a difference was neonatal respiratory distress. So these women have gestational diabetes. Some of them, as we'll see, don't have gestational diabetes. Some are on insulin, some are not. In the control group, 17% of these babies ended up in the NICU getting respiratory support, CPAP, all sorts of things, for respiratory distress. And that is not what we see in clinical practice. So I find this a little bit hard to understand exactly why the rates of respiratory distress were so high. And there was no difference in other interventions. Notably, there was no difference between the treated and untreated groups in the need for special care or NICU admission. There was no difference in the birth weight. There was no difference in induction of labour. There was no difference in caesarean section. They did find a reduction in severe perineal tears. They, of course, found that the women who were diagnosed earlier were more likely to be on insulin, and there was much more healthcare utilisation. So that doesn't strongly support early testing for GDM. The trial did show some other really interesting things. So it showed that the women who were treated early for GDM, 2/3 of them ended up on largely insulin. The women who also had a positive GTT at the start, but were retested later, less than half of them ended up on insulin. So there's something about diagnosing these same women with these same blood sugars earlier means we're more likely to treat them. What they also showed was that these women who had an early positive test and were retested at 24 to 28 weeks, when they were retested, 1/3 of them were negative. So if they'd been in this group, in the positive treatment group, they're all finger pricking away furiously and impacting on their diet and exercise and labeling themselves as having a disease and all of those kinds of things. But actually 1/3 of them didn't have anything when they were retested. And if we divide them up by the initial levels of their initial GTT, in the low band test, our current ones, where 5.1 fasting, half of them didn't have gestational diabetes when they were retested. So I find that concerning about early testing, I guess. What else do we know about early testing, and what else could we do better? Where did we get that list of risk factors from? Why do we test some women and not other women? So I think when we look at the odds ratio for having diabetes at 24 to 28 weeks, most of those things that we look at, family history of GDM, age, ethnicity, BMI, most of them only have odds ratios compared to women who aren't diagnosed with gestational diabetes of only about 2 to 3, so very low odds ratios. Really, the only risk factor that has a very high ratio for having gestational diabetes at 24 to 28 weeks, not even early, but late, is previous gestational diabetes. And even those women only have a 50% risk of recurrence. So clinical risk factors are not a great predictor of gestational diabetes. So I'll just remind you again what the pathway, the guideline is going to say. So hemoglobin A1C for women with risk factors for diabetes to diagnose type 2 diabetes. It's not to diagnose GDM. It's acknowledging the higher rates of type 2 diabetes in our pregnant population that we see now and trying to pick those women up early because we know there are benefits from treating type 2. Early GTT, instead of doing it on everybody with risk factors, we are doing it on women with previous GDM because of their higher rates of recurrence, or women whose hemoglobin A1C was a bit borderline when we did it. So if their A1C is 6.5, we're diagnosing them as type 2 diabetes. If it's higher than that, we're suggesting an early GTT. That is the rationale behind those things. Australia is not out of line with other countries. So if we look around, the US aren't recommending early testing for GDM at all. The UK are doing it on a much smaller group of women, previous GDM. India, they're doing it as a non-fasting test on everyone. Scotland, they're only doing an A1C, not a GTT. Canada, multiple risk factors, doing a screening test, so a 2-step measurement. And in New Zealand, hemoglobin A1C on everybody. So the way we've been doing early GTTs has been much more enthusiastic than other countries around the world. What other things could we do? could we just do an A1C and not do anything else? Some very nice data that's recently been published from India, Kenya, and the UK, where they've used fasting and A1C early. And if your fasting and your A1C are both low in early pregnancy, then the chances of developing gestational diabetes are much, much lower. And they are suggesting that in some women, then a GTT later in pregnancy is not required. And obviously that has benefits both for the woman having to go through that test and for just resources of doing those tests. That's not in practice at the moment, but there's certainly interesting data around that. People talk about whether they can use CGM, continuous glucose monitoring, to diagnose GDM or to predict GDM. Unfortunately, we really don't have the data around this at this stage. And because of the costs of CGM, which is not funded, there's certainly significant equity issues around that. So they're not really practical at the moment. Okay, so that's early testing. I want to talk now about diagnostic criteria, because I think that this change in diagnostic criteria is concerning to people. They think that we're missing treating women who will benefit from treatment of gestational diabetes, and that we may be causing other harm to their children to other things. And it's certainly caused some concerns in those ways. So I just want to explain why I don't think that's true. So if we look at the two big trials that we use to say that there's benefits of treating gestational diabetes, they're both fairly old now. One was an Australian trial, one was a US trial. And what's important about those trials, which showed that there were benefits to treatment, is how they diagnosed GDM in the first place. So the Australian trial, the HUS trial, you had to have a fasting not too high, or it was diagnosed on your 2-hour reading. So your fastings weren't used to diagnose gestational diabetes. In the US trial, it was diagnosed in women who had an abnormal GCT and then had a 100-gram GTT with levels that are more similar to the levels, again, that are being proposed as the levels going forward. So the levels that we currently use to diagnose gestational diabetes do not come from our trials of treating gestational diabetes. They come only from observational data. And as we've said, in those trials, that's where we saw less larger gestational age, all of those benefits of treating gestational diabetes. They came from those trials that used much higher cutoffs. There has been a specific trial done, again, by Carolyn Crowther, who's done so much good work in this space, which came out a couple of years ago, which randomized women to different diagnostic criteria for GDM. So they used fastings of either 5.1 or 5.5, and you'll note that that 5.5 is not what's being proposed in Australia. We're proposing a 5.3. But they did compare how we should diagnose and what that should mean. And what they saw is complicated. What they did see is that if you use lower diagnostic criteria, you diagnose lots more women. So 15% versus 6%. And that shows up in lots of other papers as well. They didn't find any difference in large for gestational age, which was their primary outcome. They did find that induction of labour, use of medication, use of health services, and neonatal hypoglycemia were higher in the more inclusive cohort, in the 15% of women. No difference in caesarean section or preeclampsia. So not a big sell for using tight, inclusive criteria, low cohorts. But then they did a subgroup analysis. And of course, we've always got to be a little bit cautious about subgroup analysis. This is no longer randomized because only some of the women in each randomized group were in this. So they looked at the women who fell between the two ranges. So they looked at the whole cohort, and now we're looking just at a much smaller group of women who with blood sugars in between those ranges. And what they found is difficult and confusing. What they found was if you were in the tighter group, in the more likely to be diagnosed group, you were less likely to have a big baby. You were less likely to have their composite outcome, but you were more likely to have a small baby. And this is what has been demonstrated throughout, that we don't just get rid of big babies when we treat gestational diabetes, we shift the whole curve. So we create more growth restriction. And then we have concerns about growth restriction in all kinds of other ways. We have concerns about stillbirth with growth restriction, but also concerns about the long-term impacts of growth restriction on cardiovascular outcomes, the developmental origins of adult disease hypothesis, that we're causing harm to babies by making them smaller. There was much more medication use in the more treated group, and they were delivered a little bit earlier. So it's hard to know what that means, whether it's better to use those lower cutoffs or not. Certainly on a population basis, there was no benefit for using the lower cutoffs. Similarly, there's been a number of other big trials in the US looking at how we diagnose women, looking at more inclusive or less inclusive diagnostic criteria. And if we look at HELIO, which is one of the big ones, again, we see 16% of women with gestational diabetes versus 8% of women, no difference in any of the clinical outcomes by diagnosing all of those extra women with gestational diabetes. And similarly, in another big US paper looking at different screening strategies, one-step or two-step, we diagnosed 14% of women with gestational diabetes versus 4% of women. No difference in large for gestational age, small for gestational age, cesarean section. But they did, in fact, in their more inclusive group, 14%, they had an increase in their neonatal composite outcome and adverse outcome. So there are not clear benefits for treating more and more women with gestational diabetes. There is this very interesting paper coming, which is still only a protocol, where they're randomizing women to being diagnosed either on a fasting of 5.1 or on greater than 7. And that will be interesting to see how that plays out, but there's no results to give. So in summary, blood glucose levels in pregnancy are on a continuum. We know that treating gestational diabetes based on those older trials improves outcome. There's really very limited benefit from early diagnosis of gestational diabetes. More inclusive strategies that include more women with GDM do not have overall benefit for the population. More inclusive strategies may have benefits and harms for women in the lower glucose subgroups. So hopefully that justifies where all of this thinking has come from for those significant changes. So trying to diagnose type 2 early, doing less early GTTs and diagnosing less women as having gestational diabetes early, still doing a 75-gram glucose test on everybody who hasn't been diagnosed with diabetes, but diagnosing less women as GDM by using higher cutoffs, 5.3, 10, 5, 9.0. I was going to talk about breastfeeding, but I seem to have forgotten those slides, so we won't talk about that. We'll answer questions instead. Now, I might end that and we will see where we are with questions, but very happy to chat about expressing in diabetes if people want to do that. Okay, hopefully we're back now. Okay, Q&A. And I lost my metformin slides. I lost all kinds of slides. Anyway. All right, so questions. If you're on metformin, will it impact the GTT, and why would you do it if, I'm sorry, I don't entirely understand that. I will chat just briefly about metformin though. So I think that what we know about metformin is that there is no association with congenital anomalies or any other problems in early pregnancy. And we have a number of new metformin RCTs, both in type 2 diabetes and in gestational diabetes, which have essentially shown no difference in outcome between treating women with insulin and treating women with metformin. Women like metformin, obviously, because they don't have to give themselves injections. Depending on the trial, between a third and a half of the women still end up needing insulin. The metformin doesn't put their blood sugars back into range. There have been concerns raised around the long-term metabolic profile of children who've been treated in utero with metformin based on a subgroup analysis of one of the metformin trials, but that hasn't been confirmed in any of the other trials. But that is still an ongoing piece of work looking at long-term outcomes for children in all of the metformin trials. Would metformin impact on the GTT? Yes, that's a problem. And there's not a really clear answer for that. The other things that impact on the GTT are bariatric surgery, and that's an increasing group of women where it's very hard to know. Some women can't tolerate a GTT because of vomiting and dumping, but it's also hard to know what the accuracy of it is given the different dynamics of how they're absorbing the glucose. And for some of those women, a fasting will be more useful. Okay, next question, CGM option with GDM and ongoing tech support. So CGM is not currently funded for women with GDM. It is funded for women with type 1 diabetes, and it's certainly very popular for those women and has made caring for them very different. There's a lot of enthusiasm for CGM out there. I mean, you probably all know half your colleagues have had a go. Tried a CGM, seeing what happens when they've eaten takeaway. It's bad for you. So for most women, CGM is just not going to be really required in gestational diabetes. Most of the sugars aren't going to be that much of a problem, and certainly the cost of getting CGM is a bit of an issue. Someone has said, is that ethical? I assume that's about the toboggan trial. I'm sure it went through a very clear ethics process. And I think it just reflected the fact that we didn't know what the benefits and harms of treating early gestational diabetes were. And I think that that's why we need to do RCTs. At the time of the older trials, the ACHOICE and the Landon trial for treating GDM, we were in equipoise about whether treating GDM had benefit or not. So I think that's where RCTs come in, and that's why we need very good governance around how trials are conducted. Okay, let me just see what else we've got here. Guidelines from Asian countries. I presume that means around diagnosis of GDM. So guidelines from Asian countries around the incidence of diabetes. I'm not aware of where they're up to with their early testing guidelines at the moment. Yeah, I can't say, I'm sorry. And, you know, we have to deal in Australia with our range of backgrounds and try and make guidelines that work across all of those. And depending on where you work, your population profile is going to be really different. During COVID, we only did an A1C at 24 to 28 weeks and was thought we were missing a lot of cases. So I think that's a really helpful comment. Hemoglobin A1C is not a good test for gestational diabetes. It's a good test for type 2 diabetes, but it's a very, very poor test for gestational diabetes. And although there is a lot of enthusiasm among consumers about using it, because of course it's so much more pleasant than having a GTT, it just doesn't pick up standard GDM, and it shouldn't be used for that. I think that's very, very clear that it's a very bad test. Fasting only, we also did in COVID, and that's probably something that's we're going to have more and more data about using fasting only. And if your fasting is low enough, and 4.7 is a cutoff that's often used, whether you need to have the rest of the GTT. And so it's working how to do that practically. So bringing someone in for a fasting, getting the results of that, and then whether you then just do the rest of the GTT or whether you send them away and bring them back. So there's a lot of logistics around doing fasting only, but women with a fasting under 4.7 are very unlikely to have gestational diabetes. That's not currently in the guidance. We talked about metformin. Summarise the follow-up testing for patients with GDM, insulin requiring versus non-insulin requiring. So everyone who's had gestational diabetes should have a GTT at 6 weeks postpartum to see if they have type 2 diabetes. The different hospitals have different in-hospital postpartum guidelines. The Mercy guideline is 2 tests postpartum, 2 tests postpartum per day for 2 days. And trying to pick up type 2. The reality has to be that if you were diagnosed with GDM and then you were diet managed through your pregnancy, that the chances that your 6-week GTT is abnormal must be pretty low. But certainly your lifelong risk still exists. So we need to encourage those women to have type 2 diabetes testing of some kind. And there's a lot of discrepancies around what's recommended, around yearly or 2 yearly, around A1C or GTT, and I don't think there's a clear answer on that, but certainly follow-up testing looking for type 2 diabetes. Can we use A1C to diagnose GDM, and what would be the cutoff? We can't use hemoglobin A1C to diagnose GDM. It just doesn't work. So I would ask you not to do that, but I can see why patients like it. Okay, if a patient has PCOS and is on metformin, when should we stop metformin? I think that's tricky. So if they're on metformin for their GTT, it's not going to be a helpful GTT. We don't think it's harmful. A lot of women are very reluctant to stop, particularly if they've had miscarriages before, and particularly if someone said to them, this will stop you having miscarriages. I don't think there's an easy answer to that. I think we can be reassured that it's a safe medication to be on if the woman ends up staying on it. But I don't think there's an easy answer. Women with previous GDM have an early GTT and they're positive, they do not need to retest. So once you've been diagnosed with gestational diabetes or type 2 diabetes, you do not need to have another GTT. And it can all get a little bit mixed up in the messaging and be a little bit hard to follow. But if you have an early GTT, which would only be women with GDM or that raised hemoglobin A1C of 6 to 6.5, then you do not need to have another GTT. That's it, you've got gestational diabetes. Okay, for women currently being treated for GDM based on old criteria, can we tell them to stop? So lots of people have asked me this about their own pregnancies or about their friends' pregnancies. It's not published yet. I don't know exactly when it's going to be published. Honestly, they've been promising us for such a long time. When it is published, the pathology labs have agreed to implement it. The hospitals are in a little bit of flux, and different hospitals will probably implement in different timeframes. And at this stage, it's not quite clear what the Royal Women's are going to do. So I don't think that you can tell them to stop now, unfortunately, much as I would like to. I think that the current guidelines are the numbers that we have. The crossover, so if it was published tomorrow and she was diagnosed yesterday, I don't think there's an easy answer to that. I know what I'd do if it was me, but that's not really helpful to me. I would stop testing, but that's not really helpful. So there will be a crossover period that's going to be really, really messy. Hopefully not nearly as difficult as the crossover period when we brought in the current guideline 10 years ago, when every single organisation moved at a different time over a period of years. So hopefully it's not going to be as bad as that. Hopefully we can all move in a reasonably concordant timeframe. High risk or past GDM patients get a 16-week GTT. So I think that's been different. So the gestation that people have done their early GTTs has been quite different in different places. Different practices have come through. So some women are having them as early as 4 to 6 weeks, which is partly a problem to do with the fasting, high fastings at that stage, and also a problem for the fact that many women are feeling quite unwell on a GTT. It's quite unpleasant. So the advice now is to move to the 10 to 14 week gestation mark. And that's a compromise between partly some of the subgroup analysis out of the Toboggan trial, partly trying to get around the early fasting levels and around the nausea and vomiting that many women are experiencing. So 10 to 14 weeks with the new cutoffs. Do we have any twin studies? I am not aware of any twin studies in gestational diabetes, but if you find any, please let me know. We do have lots of big studies, but I don't think we have any twin studies. The only thing I would say about the GTT, which you may choose to share with your patients or not, is it's not a particularly reproducible test. So if a woman does one today and does one tomorrow, she may get a slightly different result. But you can choose to share that information because it's not very confidence inspiring. Do women with other risk factors like morbid obesity need an early GTT at 10 to 14 weeks? No. So that's a very big change, that the only risk factor that is being advised for an early GTT is previous GDM or hemoglobin A1C of between 6 and 6.4, and not expecting to see an awful lot of those. That's quite an uncommon finding. So all of those other risk factors that we used to say, you need to have an early GTT, and people interpreted that in different ways. Now it's only previous GDM. So the result of all of this is going to be a lot less women are going to be diagnosed with early GDM, really a lot less, because there'll be a lot less tests, and a lot less women are going to be diagnosed with GDM overall because of the increase in the diagnostic criteria. So my expectation is that we're going to cut our GDM rates by about 40 to 50% based on the Mercy data, which I think is probably fairly representative. So there's going to be a lot less GDM out there. And that's why we need to talk about why that's a safe thing to do, that we're not causing harm by changing those numbers. think that is all the question. Oh, no, sorry, there's more. Future risk. Oh, okay. If you were diagnosed on the old criteria, do you need to have a GTT postpartum? I don't have an answer to that, but it's a very good question. I don't know. I think you could look at their other risk factors for type 2 and think about whether you would test them for those reasons. Apart from that, we're just going to be caught in this mix of old and new criteria for, realistically 6 to 12 months. And it's just going to have to be on individual decisions. I don't think there's easy answers. Oh, somebody's saying thank you. That's nice. Does it matter what gestation the hemoglobin A1C is tested? It makes sense to test it early because you're seeing them for their booking bloods. If she does have type 2, we want to know about it and do something about it. So it makes sense to do the A1C early. And what we are trying to pick up is not pregnancy changes that a GTT is trying to pick up. We're trying to pick up what's been happening in the last 3 months. So it's not so gestation dependent and doesn't have those same problems of the raised fasting sugars in early pregnancy. So I think that when you're doing booking bloods would be the time to do the hemoglobin A1C. Okay. Any other questions? Happy to answer questions about other topics as well, because Beck, who was on, we were talking about RHD testing today, so happy to talk about that too.
Dr. Shub, thank you very much indeed. I think you've answered an awful lot of questions there, but I'm mindful of time. If you've got a couple more minutes, I think there's a couple that popped up in the chat we may not have covered.
Yep, sorry. I'm sorry. I wasn't looking at the chat.
No, I'm happy to read them out for you, Dr. Shub, if that helps.
Yeah, great.
So this hopefully might be one you'll get. The role of aspirin in GDM and obesity.
Sure. So aspirin's, got lots of aspirin's one of those things we've got really good evidence for, and we know what it does. And what it does is it reduces the risk of preeclampsia before 34 weeks. It doesn't change the risk of preeclampsia after 34 weeks. So term preeclampsia, of course, much, much more common than preterm preeclampsia. And aspirin does not make a difference to term preeclampsia. So when you're deciding whether to put someone on aspirin, and remember, you've got to 16 weeks, it just needs to start before 16 weeks. There's no great rush. You need to think about what their risk is for preterm preeclampsia. Now, you can use the algorithm which incorporates the biomarkers, BMI, all of those things. So that's what was used in the trial that showed that aspirin worked. So biomarker screening and risk factor screening, and yes, you're at high risk. No, you're not at high risk, so you can do that. There's a patient cost to that, as in an out-of-pocket cost for the pathology. So you can also just look at her clinically, and it's not as reliable. But on the other hand, aspirin's not a particularly problematic intervention. So largely, if someone didn't have preeclampsia last time, then their chances of getting preterm preeclampsia this time are very, very low, even if they're obese, even if they've got gestational diabetes. Primips, of course, we don't have that to help us. And so, arguments have gone out that all primips should be on aspirin. That's not been widely accepted, but that would be an option. You could say primips who have additional risk factors, such as high BMI. You largely aren't going to know if she's got gestational diabetes before 16 weeks, so you're not going to be able to base it on that. It's a relatively low risk intervention, but it's just important to remember what it's preventing and what it's not, and it's not preventing term preeclampsia, and the risk of preterm preeclampsia in a multi without significant other renal disease, pre-pregnancy diabetes, whatever, is very.
Thanks, Dr. Shub. I may have one more for you, if that's okay. We have a question here that says, any changes to postnatal follow-up of GDM and how often HbA1c should be done?
So we talked just before about 6-week follow-up, and then the follow-up after that is quite controversial, and there's lots of options that are probably all very reasonable about whether it's yearly or 2 yearly and whether it's A1Cs or GTTs, and they're probably all very reasonable options, and that's one side. And I'm sorry, I'm not quite clear on what the College of GP recommendation is on that at the moment.
Thanks, Dr. Shub. And maybe just one last one, role of calcium in GDM.
Oh, yeah, sure. In GDM.
Yes.
So I don't think there is a role for calcium in GDM. So we've talked about in the past about calcium for prevention of preeclampsia. And even that is becoming less and less clear. So more recent meta-analysis of the data with some different statistical techniques has really brought into question whether calcium does actually have a role in prevention of preeclampsia. And so the Mercy guideline no longer recommends calcium for prevention of preeclampsia. I'm not sure where other hospital guidelines are on that, but it's become much less clear. The current SAMANS hypertension in pregnancy guideline does still recommend preeclampsia. Does still recommend calcium, I'm sorry.
Well, that's great. Thank you very much indeed, Dr. Shubb. I'm very mindful of time. I think we've pretty much gone according to schedule, and it's been a fantastic presentation. Thank you very much indeed. Been very comprehensive. On behalf of Northwest Melbourne PHN and Mercy Health, we thank you for your time this evening. I'd also like to thank my colleague Yvonne, who's done the back-end support, and also my other colleagues who joined us tonight from Health Pathways. So we had Sharon Tyson from Mercy, and we had Crystal Barbetto from Health Pathways. And finally, please, this is all very important, folks. We thank you for joining our session this evening. I'd just like to confirm that following the session tonight, you will receive within a week an email which will include the slides and the resources discussed during the session. You should also get your attendance certificates within the next 4 to 6 weeks, and your ROCGP CPD hours will be uploaded within 30 days. The other thing I'd like to say is we've always got lots and lots of different educational webinars and events coming up. So please keep an eye on the Northwest Melbourne PHN events page. You'll find out about more information on events there. And confirming again that the session was recorded, and we'd love you to view this session, and we'll get that to you next week. And last but not least, the other thing is we do really, really value your feedback. So there's a QR code there, and I think we may have also put something in the chat as well. If you wouldn't mind, please taking your time to provide us with some feedback on tonight's wonderful presentation. It'd be very much appreciated. Feedback's always very beneficial because it helps us to hopefully try and develop our sessions and present them to you in ways which are very useful to you as participants, and also for our facilitators as well. So thank you very much, everybody, for joining us tonight. Thank you again to Dr. Shubb for a wonderful presentation, and for our colleagues from Mercy Health, Health Pathways, and from Northwest Melbourne PHN. I'm Phil Flanagan. Have a great rest of your evening. Cheers.